A warm welcome to everybody, and sorry for the slight delay in starting this afternoon's meeting. We've had some technical difficulties, but we're all sorted. So without further ado, we are going to start our workshop on psychologically informed collaborative conversations, or PIC C for short, exploring the past, present and future of our training programme. And today we've got a range of speakers lined up who have been involved in PIC C in various different ways, clinicians, experts by experience, and people who have attended the training programme. We have a slight change to our programme this afternoon, and unfortunately Professor Frank Keith is unable to join us. But in true PIC C style, we have pivoted, we have been creative, and we have change the programme so that we can still bring you a flavour of PIC C past, present and future. My name is Claire Copeland. I'm a clinical psychologist working at St George's Hospital, and I've been involved in PIC C from the start, and it's been a real pleasure to see how the programme has developed. On the slide that I'm just about to show you is a picture of the original group at an event in March 2020, where we launched PIC C, and from there, PIC C has grown. So I'm going to hand over now to my colleague, Rebecca McLaughlin, who's going to take us through how PIC C developed and the key points along the journey so far.
Hi, good afternoon, everyone. So I'm just going to spend a few minutes now talking with you about how the PIC C programme developed and just reminding you of the key components of PIC C. So the project really started from a clinical base with clinicians at St George's University Hospitals in South London and Kingston Hospital, recognising a challenge. Many physiotherapists within their teams were talking about difficulties working with people presenting particularly with pain, who absolutely understandably were experiencing moderate to sometimes very high levels of psychological distress. Physiotherapists within the service explained that they sometimes felt a lack of confidence in working with people in a psychologically informed way and exploring biopsychosocial assessments and interventions with patients. So the teams at the hospitals began to explore the literature around the area and to work also with the PPA, who were noticing similar feedback from their membership. And they put their collective kind of wisdom together and applied to QLab and the Health Foundation for a funding call. And this enabled the team to work in collaboration on a year-long innovation project to design and implement an evidence-based training and supervision programme to increase physiotherapists' confidence in delivering psychologically informed care. As Claire said, the team that were recruited, which included clinicians and researchers from St George's and Kingston Hospitals, from the PPA, and Professor Frank Keith from Duke University, and 2 patient representatives who were integral members of the team. We all started working together in 2020 on a year-long pilot project. I'm not going to talk in a lot of detail about the co-creation of the project, because all of this information can be found on PPA and NIH and HIN websites, and we've got the links to those on future slides. But we just really wanted to highlight that PIC C was co-created with people with lived experience of pain, absolutely embedded within the project team and as integral members throughout the whole co-creation cycle. And we think that this is a real strength of PIC C, and that it's been a very important part of both the development and the ongoing kind of expansion of PIC C as a programme. So I'm going to leave this slide for a moment to enable you to have enough time to use the QR code if you'd like to access the link to the full pilot project report, which was published in June 2021. And this will give you a much more in-depth overview of the development of the programme and also the findings from the pilot run of the delivery of PIC C. But just to highlight a couple of key findings from the pilot programme, we found that through delivery and use of PIC C, physiotherapists reported increased confidence with using psychologically informed approaches, which was our key aim of developing the programme. Physiotherapists told us that supervision was felt to them like a key aspect that led to the change in their practice and change in their confidence. And they recognised that participation in the programme had led to improvements in work-related well-being, which we hadn't necessarily, it wasn't one of our core aims at the start, but we were really, really pleased to see that coming through in the pilot data as an outcome of PIC C. So since we've finished the pilot study and the funding from the HIN finished at the end of that project, the PPA have now taken on governance of PIC C, and they continue to provide the admin for the course, which you can access through their page on the website using the QR code on the slide shown. We also just wanted to highlight at this point that in the time since the pilot programme finished, we have also authored a paper looking at the development of the programme and exploring physiotherapists' experience more broadly of psychologically informed practice. So we'd really encourage you all to take a look at that. And again, the QR code is there to help you to do that. So that's been a whistle-stop overview of the development of PIC C, and I'm going to hand over now to Dermot to share some experiences of PIC C participants.
Hi, everybody. Yeah, so as Beck said, this was the paper that just came out. I'm just going to move on. This is just a summary. We were aiming to, understand physio's thoughts on psychologically informed practice in order to develop the training. So after this, you'll have access and the QR code takes you to the paper. So you can have a look there yourself and get a sense of how we designed the program. But what we thought would be helpful to do is to consider what the program is, the content of it, and then to hear from people who have graduated of the program, who have done the training already, because we were reflecting ourselves as a team that, this is 6 years now since we've developed it. So it'd be nice to get a sense of how people are using it and finding it after the training. But to give you a sense of the training, it consists of 2 8-week blocks. The first 8 weeks are 90-minute sessions, and we cover a range of topics. Here on the right, you can see each week we cover a different aspect of psychologically informed practice, beginning with therapeutic alliance, and then working through a range of different models through to considering how we support people when they experience challenges, how to build on progress, and then how we can ensure that we are offering appropriate endings to clinical interactions with people. So that's just an outline of the training program. The supervision block is also 8 weeks. These are hour-long sessions. It says here up to 5. We have actually changed that. We find between 5 and 10 participants works best in our smaller group supervision. And the intention here is that it's very much, if you're familiar with action learning sets, it's a model whereby the group themselves share and discuss cases. Somebody presents each week a case from their clinical practice, and the group share their thoughts and ideas, drawing from the content they had learned on the first 8 weeks of the training. So it's an action learning set. We want to supplement what's taught in the sessions and what's discussed with resources. So we've developed a comprehensive handbook, which we've just recently updated in the last year, actually, that also has a range of additional links to videos, to podcasts, to more recent literature and peer-reviewed publications that are related to the training. So, every participant who comes on the training is given access to this handbook. And this is just from the original pilot data to give you a sense of what changed for people. So the top row, the pre-training, looking at what clinicians might identify as psychologically informed that they might consider relevant and that they may use in their practice. And really, what was shared was quite minimal. So the clinicians demonstrated an understanding of reassurance that pain doesn't mean harm. They might use pacing, and they would be aware of flare-ups as a part of living with any long-term condition, including pain. But after the training, we found that the clinicians, the participants, had a much greater breadth of awareness of different strategies, tools, and techniques that come under the umbrella of psychologically informed practice. And what we thought would be nice would be to hear from people. But before I do that, I just want to say that since the pilot, which was 2019-20, well, 2021, around the beginning of COVID, since then, we have run a further 11 programs. We've approximately 210 participants go through the program. And what you might notice is that year on year, we are experiencing a growth in that there's more awareness and more demand for the training. So this just gives you an overview or of a flavour of how PIC C has been developing since we did that pilot of the program. So what we're going to do now is just share some videos. I really hope this works. Our tech has been not wanting to play ball with us today, but we're going to give it a go and see how we get on. And I'm going to mute.
Yes, I've had patients after sessions, perhaps especially initial sessions, where they may have been involved with our service before, but for whatever reason have not engaged. And so there's been a number of failed episodes or episodes that have ended very abruptly, or they've had to be discharged. And so I think there's been a lot of anxiety around sometimes people coming to sessions, but I've several times had comments around, oh, this isn't what I expected, or this is different to what I thought it would be. You've made me feel more relaxed, or you've made me feel listened to. And that's been really positive. And we've found a few times of actually patients being able to go a bit further in their sort of therapy journey or in that episode of care. So which is really is encouraging, really encouraging, but it's been positive. Yes, so within our multidisciplinary meetings, within the neuro team, following the model that we've used in the PIC C course, we've been starting to try and implement that more. So just recently agreed with my line manager that certainly at least every quarter or every 2 months we will set aside, extend the meeting in order to be able to have that peer supervision session for some of our very complex patients. So which is really positive that we've been able, that's been agreed.
So that was Camilla. As you can see, Camilla is a neurophysiotherapist, and one of the things we've been exploring over the past few years is the application and the usefulness of this approach in disciplines outside of pain. So originally this came from our work within persistent pain, but we've been finding that actually as it's grown, as more people have come to this, that people are finding it relevant and useful in a range of different long-term conditions and disciplines. So that's really encouraging, and Camilla, I think, shared nicely there. So we're now going to have a look at another thing that we've been doing is testing this in different countries. So we ran a course in Ireland, and we're going to hear from Roisin now. So I'm just going to move forward and put myself on mute so that you can listen to Roisin.
I loved it just as a chance to really slow down and reflect on what we're doing. And I really appreciated the supervision bit. So I liked the training, but I really found the second part useful. And hearing from other clinicians in different clinical areas, I thought that was really good. You know, because there was people from like weight management services and I think like respiratory community, and the common themes of just being able to communicate and do the work with people, you know, and taking them through this kind of rehab journey. I really appreciated that, even though I know we were kind of pain was sort of the kind of main condition. From my perspective in Ireland, there is not much time to talk about this stuff. So a lot of the courses and the kind of conversations now in physio are around like assessment, triage, diagnosis, the kind of first bit, and reading scans, doing injections. And I just feel like we're losing the time to reflect on the actual work that we're doing with people. And I don't think, now I could be wrong, but I think a lot of this stuff would have been quite new. So I was even thinking there, like even having the time to talk about therapeutic alliance, like noticing your own reflections and what you're bringing to consultations. Like I never ever hear that talked about. And noticing your own responses with people, and even the idea of boundary care that came up one week of, you know, being kind of clear on what you can offer and not offer. I don't ever recall that being talked about in any kind of circles that I'm in. And I think that's really helpful for physios, you know. And some of this stuff takes the pressure off. I think it'll be really useful. And all I want to do is to kind of help physios to feel a bit more supported, because I hear these conversations about how hard it is and how frustrated they get and how the patients being so stuck kind of influences them. They feel so stuck, and we've no space to talk about that.
Yeah, lovely to hear from Roisin and just some ideas on one, the content, but also that kind of reflexivity and kind of bringing awareness to our what comes up for us when we're practicing as clinicians. Next, we're going to hear from Jenna, just to give the perspective of Jenna is a clinician, but also somebody who commissioned the training, and just give thoughts on why she decided to commission it for her team.
I suppose the reason we decided to book a PIC C course to run internally in our trust was that it had been recommended by our local pain physios in different departments across our trust. And when we researched it, we saw that there was a really good evidence base and a pilot that had shown that it worked for other trusts, and the website was really good with kind of explanations from patients and staff on how it helped them. I liked that the course was affordable and for our trust to fund for 20 clinicians, and we could incorporate it within the working week, so it wasn't requiring any additional time off work or study leave for clinicians, which helped with our clinic capacity, which is always an issue, but also that it kind of drip fed the information over a period of 4 months, so once a week, 1 hour a week for 4 months, which, having done a PGCE in my educator role, I realised that that is so important for like that deeper learning, because it gave us the opportunity to reflect on what we learn each week, apply it to our patients clinically, feed it back the following week, and then particularly the second half where you're talking through cases and everyone brings a case and everyone discusses that case. That was really helpful way of really integrating it into our caseload of more complex or persistent pain or chronic condition patients. So yeah, that was really helpful. Much better than a 1-day course where you just sit and watch and you don't really have time to reflect and apply it. So I definitely think for a deeper learning and change in our practice, it was brilliant for that. But we did a feedback with our local colleagues where we said, right, we're going to offer peer review for our colleagues who didn't do PIC C and have got complex patients, and we can those that have done the PIC C course can sit in on that patient and give feedback based on what they've learned. And that was our way of kind of disseminating amongst the wider team. And that worked well. Or having colleagues who didn't attend PIC C and maybe were struggling more with complex cases do a case-based discussion with someone who had done the PIC C course and talk through some strategies, and that had good feedback as well. And overall, I think the general team feel a bit more confident and capable managing their more complex patients, which sometimes can feel, if you're not getting anywhere, a bit heart sink and like you're not sure how best to help someone. And I don't think there's as much of that feeling amongst the team. I think it helps with, staff satisfaction and enjoyment of their role and improve patient outcomes. I think it was a really positive and valued course for the wider team.
So that was Jenna, and I think it's really nice to hear some ideas on the practicalities of it. If you're thinking about commissioning PIC C as a training program, but also I think something that perhaps we hadn't considered as much, but is really interesting to hear about the ripple effect throughout the culture within a department when a cohort do it and how they support other members of their team. So now we're going to kind of go again overseas, this time to Denmark, to hear from colleagues that we're collaborating with at the University of Northern Jutland, UCN, and they are looking at applying PIC C in their undergraduate program. So we're going to hear from Anne-Katrine and Heidi, who are sharing just what they've been doing there.
I suppose the reason we decided to
Heidi and I was at the IFOM teachers meeting a few years back. I don't remember.
It was in Ghent 2023.
Yes. And we heard Tim Noblet talk about what you guys have done with the PIC C, and we were just right away we were interested in how we could learn from what you guys have done and then maybe integrate some of it or all of it as it has turned out to the undergrad program at the University College in Northern Jutland.
Obviously, your material is meant to be teach to educated physios, and we had a translation work to do there. So that's what the years have been about since 2023. So a bit of developing work. I think another thing that we looked at in the first place as well is the time frame that you got for delivering PIC C. We have to narrow it down to like I think maybe two weeks.
Yes, two and a half,
3 weeks. That means that it's more intense. They have the subjects like 2 or 3 times a week. And that means that the time for reflection and integrating it is different, of course. So we have been working in these iterative processes so far, and currently we are going through our second round, and we have adjusted things slightly along the way to try to accommodate some of the things that the students tell us, and hopefully it means that it is landing a place where we can see all the good things from the PIC C.
The response that we have gotten from some of the students is that the alignment and the way that we sort of repeat some of the same we repeat the material in sort of the same ways over and over and over again, and then we also have adapted your practical supervision part into their clinical practices, the last one, to help them sort of incorporate the knowledge into their therapeutic practice. I think that's one of the experiences that we have had that is very interesting, and that we are also inspired to maybe adapt into some other parts of the curriculum in some way, because it's interesting to work in that space where they're with the patients, but also we can sort of help them transform knowledge into skills. One of the things we talked about after we saw the way that you built your PIC C teaching materials was that maybe we did have some of the sort of subjects or themes in our curriculum, but somehow the students had trouble trying to sort of use the knowledge and transform it into actually using it as skills in their physiotherapeutic sort of practice or contact with students. So we wanted to be curious about what the way you presented it might help them understand the sort of the alignment throughout the different modalities we were showing them.
And they don't see patients in their everyday life. They have other topics as well. And that means that maybe for the students, it's sometimes just another subject on top of other things they have to do. And that's some of the things I think we are still trying to figure out what's the best way. Also thinking about that it could be more spread out through the whole education, because we sometimes we think that some of the subjects come in too late at the 6th semester where we have it now, and we want them to have some of these ideas from the very beginning, and they do already have that, and that can feel like repetition. And even though that we think that you're not completely educated when you have heard things once, that's a problem if we don't think about that along the whole curriculum. So we're definitely looking into incorporating it as a thing in the future.
Also, I think one of the things that we are trying to, usually when we adjust the curriculum, we are just reacting to something and we're changing something and new knowledge occurs and we want to integrate it. But this time we've tried to sort of make it into a research project so we can document every step of the process of changing the curriculum. And also this fall we are gonna do sort of measure whether or not this has changed, how well the students are able to sort of use psychologically informed practice into their clinical settings. So we're also trying to sort of learn from the process in a more structured way than we usually do, and that has also been sort of an ongoing process, learning how can we become better at evolving the curriculum in a more structured way, or with a better understanding of the processes that we actually sort of try to integrate through that process.
So what I think Claire mentioned earlier, a part of the spirit or the culture of PIC C is this kind of iterative working with what shows up. And what's been lovely working with Anne-Katrine and Heidi and the team at UCN is how they've explored and been curious about the PIC C and the content and thinking about some of the challenges of applying it with undergraduate programs. You heard them there sharing some of the challenges around students who may not necessarily have a life experience of clinical practice to draw upon in supervision, but nonetheless how it's still relevant, alongside ideas on how where they may lack in clinical experience, they have awareness of these concepts, and so they are more aware of them and how they might show up and present in their clinical placements and hopefully throughout their career. So this is just another exciting way that PIC C has been developing. So that's a brief selection of some people who've been on the program or training or been working with us. I'd like to thank them all again, Camilla, Roisin, Jenna, and Katrina and Heidi. And what we're going to do next, I think, is hear from Chris, one of our lived experience partners who helped to design the training, just from a lived experience perspective. So I'm just going to move the slide forward while you're doing that. Oh no, hang on, it's that way. There we go. Camera is here. This is the button to move it forward. And this one. And just click here.
Okay, right, sorry about that. Just trying to work out how it all works. So yes, as Dermot says, my name's Christine Price, and I've been one of the experts by experience, whatever you want to call it, involved right from the start of PIC C, and I've continued to be involved, which is a huge pleasure and privilege. My background, I suppose, if you want to call it a background, is I'm a person living with persistent pain. I have sciatica with neuropathic pain, unfortunately. So this is just briefly what I plan to talk about. We may not get through it all, but a little bit about me. I'm going to talk about the spectrum of participation because I think that's really important, and I'll explain that. And my experience of co-production in terms of PIC C. And if we get time, just a couple of thoughts about patient involvement in such projects. So this is the start of my sciatica journey. So I've lived with sciatica now for 15 years, following what was basically a manual handling injury. I basically thought that I was Hercules, and I decided that I was strong enough and good enough to clear out the loft of a large old Victorian house. And of course, I could do it on my own. I mean, who can't do it on their own? But that did land me in a bit of trouble. I woke up one Saturday morning, absolutely fine, went for a nice cup of coffee with my husband in a beautiful spot in Dorset. But by lunchtime, I found that I was in excruciating pain and could barely walk. I ended up being hospitalised, so I rang 111 and said, actually, look, I've been able to wee for the last 24 hours. Does this matter? And of course, they said, yeah, that's quite important, really. And I got bundled off to A&E in an ambulance, and I ended up remaining in hospital for 5 days. I didn't know at the time, but of course they were looking at cauda equina. I was in a pretty dreadful state, but I was eventually discharged. As I'm sure you're aware, sciatica is a spectrum. And unfortunately, I live at the severe end, the neuropathic end of that spectrum. I think burning and tingling might be a little undersold in terms of neuropathic pain. This is how I describe my neuropathic pain. I compare it to when I was a kid and I fell off the bike, and that's nociceptive pain, and that's a sort of familiar pain. Neuropathic pain is absolutely something else. And I found it a hugely, hugely frightening experience. Neuropathic pain, I feel, is unpredictable. It's untamable. I have the severe stuff and still get that. And it's, not pleasant at all. So I had a really difficult journey back from that manual handling injury. I had to basically learn to walk again. I found it very difficult to sit down. I was on, you can guess it, I was on copious amounts of opioids and other medications. I lived in the land of the fairies. I lost my career. I was a teacher at the time, but I couldn't teach in the state that I was. Hugely difficult, as a lot of people experience who are living with severe pain. I had a lot of input. So this briefly shows you the number of procedures I had, and the number of clinicians I experienced in my first 5 years of healthcare. I had back surgery. I can remember being told by my rheumatologist, well, that failed, so there's not a lot more that we can do with you. You're going to live with this for the rest of your life, but we'll put you on a spinal cord stimulator pathway. That was a horrible process, but thankfully in the end I decided to turn that down. But I did have quite a lot of experience of hospitals and various clinicians. I was helped after 4 years by a particular physiotherapist who you may have heard of, called Matt Lowe, who treated me in a much more person-centered way and helped me to learn to live my life again, and helped me learn to get off medications and you know, just be able to live a better life. So I've been lucky. There were many years that I could only dream of being able to live an active life, but now I can. And if I just show you, it's only a little snippet of video, if I can work out how to do it. This is my little dog, Bailey. But look, I can run. I could never dream that I would be able to do that ever again at one point. This was in January, and if I just play it you again, look how slow he is. Isn't he slow? Right. Now look what happens. So this is him. I'll show you in a second. This is him now, and this is practice for a relay race, and I'm supposed to be able to keep up with him. But look, I haven't got a hope. Not a hope. But that's my next goal. I'll just play it again. I've got to be able to learn to run that fast. But as I say, for many years, that was a distant dream. This is a diagram, a drawing that was drawn for me, which perhaps shows my pain. So I'm not standing up, so you can't really tell, but I think that I look fairly normal. If you met me on the street, you wouldn't know that I live in persistent pain. But actually, it's my right leg that's affected. And the way I think of it is that my right leg has sort of come from Poundland. It's sort of there and it sort of works, but it doesn't work very well. But my left leg, my good leg, came from John Lewis, and that leg works beautifully. But I do have when I'm walking around, it often feels like I'm trailing a tree trunk with me. I get the sensation of fairy lights, which is actually quite pleasant, or the twinkling electricity. What isn't so pleasant is that I walk on, it sometimes feels like a walk on a tennis ball. And one of the worst symptoms is I can feel like I'm dragging an ice cube. My whole leg is like an ice cube. But one of the sayings that I've always lived by is very much, what doesn't break you makes you grow. And I think all of these experiences have provided me with knowledge, wisdom, and insight that I can use to support healthcare and to hopefully make it a better place for future patients. So, as I say, I've been involved in patient engagement with PIC C, but plus other things. And this is one of the diagrams that I like to show people. It's from peoplehub.org.uk with permission. And this shows what I call the rainbow of involvement. And you can see that it changes from clinicians informing patients what they're doing to the pot of gold at the end of the other end of the rainbow, which is true co-production, and and all the different stages in between. And the story that I usually tell about informing is I was once invited to patient meeting with clinicians because Dorset were developing a new MSK. It's on a timer. I can't knock it off quickly. Sorry. Dorset were creating a new MSK website, and they invited patients to actually provide input. But every time we said, oh, well, I think you should do this, or have you thought about doing that? Or that doesn't quite work. We wouldn't like that as patients. They said to us, well, that's unfortunate because we've developed it and it's too late. It's already in production. So I don't know why they invited us. I mean, the custard creams and the bourbon biscuits were great, but actually they were informing us. They weren't actually involving us properly. Whereas my experience of PIC C has been right at the other end, where we have genuinely co-produced PIC C with patients at the heart of it and involved throughout. Oops, let's try and send it along. Here we go. So this is what I think co-production relies on. I think it relies on the appreciation of different perspectives, knowledge and experiences. My perspective is different to the clinicians involved. Different amounts of power, responsibilities. I don't have the same responsibility as other people. And most importantly, actually, from both sides, an investment of necessary input of time. I'm having trouble with the technology. Right. So I think this diagram shows the investment of time quite nicely. It takes the rainbow and it shows if you're going to inform us, it's not going to take a lot of effort from you and hardly any from us. But if you're going to co-produce with us, it takes a lot of effort from both sides. I'm having trouble with the technology. There we go. I'm just going to send it along a little bit. So co-production, as far as I'm concerned, needs strong and trusting relationships, and it relies on honesty, good communication, and a willingness to cooperate. And that's my experience of PIC C. I was involved from the start. I think you might need to come and send it along. Right, so now I have a helper. Okay, so for me, as far as the patient's involved, I believe that we have to be actively engaged, but we have to be actively engaged from the beginning in creating the agenda and not just responding to it. So this is what happened for us. So there were 2 patients involved in the development of PIC C. We were involved absolutely throughout. We attended all meetings. We developed film content, presented at conferences, co-designed everything. And we're also involved in critically evaluating the project. My experience of being a patient partner on PIC C, as I said, we were involved from the beginning. We have been very much an equal voice and an equal partner, and very much genuinely valued and empowered to be part of that team. Importantly, expenses were fully paid. And we found that obviously when you're talking about your own story, it can be quite emotive. So we were both supported in our own personal difficulties, if you like, of being able to retell those stories. But perhaps most importantly, we found it to be just fun, productive, worthwhile, and we have managed to form some good friendships and some very valued colleagues. So thank you.
Good help. Let's stop sharing.
Yeah, stop sharing.
Okay, hello. My name is Claire Jacobs, and I'm here in kind of a number of different roles. I'm co-chair of the PPA and also a facilitator on the PIC C program. And I just want to share a little bit of our meandering journey from today, and we have a number of us here. So this is the kind of the expansion really of PIC C into the paediatric world. So this really started with collaboration between professional networks and an interest in how can the material that we're doing be adapted and supported for the paediatric population. So over a number of years, really, it started with supervision groups, it started with just discussions, and then we ran a program. We've now done 2 cohorts programs along with the Association of Paediatric Chartered Physios and the PPA. And we're really building on exactly what Chris has said. You know, we've done the cohort, we've done the work, and we wanted to really evaluate it. So we've done focus groups and feedback. And over that time, we kind of recognized that there was a couple of things that we could maybe bring in that might be more related to the physios working with pediatric population. So we secured a grant from the CSP, and we, using the knowledge through PIC C in terms of the co-production, we worked with our patient partners, and we developed 3 videos that we are now planning to use on the next PIC C program for pediatrics. So we focused on a couple of areas. We looked at eliciting values. We looked at therapeutic alliance. So that slight difference when there was the triad of the patient, carer, and the therapist, and also when there was conflicting values. And that's really where we've kind of focused a little bit on today, because that's really led to some really interesting work in how we can just learn a little bit more about how we work with those triads. And that's why we've got our speaker. And I'm going to hand over to Jane to introduce Sara. So thank you.
So hi. So yes, I'm Jane Robinson. I'm one of the physios at Sheffield Children's Hospital, leading the pain management service there. And it's been a great pleasure to collaborate between the PPA and the APCP in developing some resources with more paediatric specific content. And then as things go along and you talk about things in the various places you're talking, one of the spaces that I've been occupying is a space on the MSK committee of the APCP, who produce a number of different courses as well. And because I've got a background in persistent pain management, persistent symptom management, I was invited recently to speak on the otherwise very physio-based enhanced spine course. So what I wasn't particularly aware of at the time, but became very quickly aware of thanks to her activism, was the Dr. Sara Hauber. So she had also been invited to speak on that afternoon, and she very wisely reached out on LinkedIn and connected us to have a discussion about what we were going to talk about. So it's my pleasure to introduce Sara to you this afternoon. I'm sure she'll give you a bit more of an introduction to herself and her work. But what's been great to do is to start to understand what's in the air at the moment in terms of understanding what paediatric physios do, in terms of therapeutic alliance and how they have to manage that
with complex systems. So I'm just going to get somebody with a bit more IT tech. Hey, there we go. So, Sara, thank you for joining us.
Yes, Jane, it's my pleasure. Thank you so much for the introduction. And yes, as you mentioned, we spoke together at APCP Advanced Spine course a few weeks ago, and I wanted to introduce you all who are interested in psychologically informed collaborative conversations, or PIC C, to my work and my perspective on the PIC C program. So I am really a communication scholar. So my master's degree is in health communication, in particular social support in healthcare settings. And I recently completed my PhD in physiotherapy, but bringing to it my perspective as a communication scientist. So I was particularly interested in and ended up studying for 4 years the phenomenon of nonspecific back pain in adolescent patients. And I'm very curious to know if you all have access. I know if you're on your phone, it can be kind of strange to find access to this, but if you have access to the React button, if you can give me a thumbs up if you are a pediatric physio, or if you can answer yes in the chat if you don't have access to the React button. I'm curious how many of you are currently working with kids. Okay, we've got a couple of thumbs so far. Good. All right. Many of you. That's wonderful to see. So you may have, as Jane alluded to, and also Claire alluded to this, experienced some challenges that come up as a part of this triadic relationship between the pediatric patient, one or more of the parents who are generally in the room or at least at your setting with their child, and you yourself as the clinician. And so in my research, I was mostly fascinated by this triad because of my research in social support. So every relationship will have a dynamic. And when you're a pediatric physio, as you know, you're not just treating your pediatric patient. You also have, like I said, a parent or a caregiver involved. And the dynamic between the parent or the caregiver and the child is going to be present in your sessions for the child, whether the parent is actively involved or not. And in my interviews with clinicians, with pediatric physios, mostly pediatric physios, although some other specialties as well, there was a lot of discussion about this dynamic, this triadic communication challenge, and building a therapeutic alliance between yourself as a clinician, the pediatric patient, and the parent in order to do what's best for the child. And what's fascinating to me is that what isn't talked about enough, and what came up in these interviews, was that there wasn't enough training in how do you do this? How do you manage these communication relationships in the clinical setting, especially when you don't have a lot of time? And this is where I think PIC C is brilliant, because what PIC C is teaching is that as a clinician, your clinical skill is absolutely necessary. But what's also necessary is your people skill. So how do you respond to another person when they are bringing distress, which pretty much everyone at least in a pain clinical setting, but pretty much everyone, I'm going to guess, in any sort of healthcare setting, there's something distressing going on or they wouldn't be there. I myself have been a patient many, many times. I had severe scoliosis as an adolescent. I was in hospitals and clinics every 6 months at least. And in fact, just last year, I had an 8-month episode of daily widespread pain. I ended up recovering from that because of all of my training. But distress is a part of being in a clinical setting. So PIC C, what I love about it is that it's helping you be a human who is responding to the emergence of the moment with another human who may be or probably is experiencing some kind of distress. So that's a little bit of the background. I could talk about this for days, so I'm going to try to focus and really hone in on something that Christine just talked about with her experience of being a patient partner in the development of PIC C. And I thought it was absolutely brilliant. What was it? The People Hub rainbow that she showed with from informing to co-production. And what I would welcome you all to think about as you're, especially in relation to the pediatric physio setting, or in fact, pediatric pain, which is my area, the co-production of a program like PIC C, you can use all of those steps and goals in what I would call your co-production of healing. So approaching the young person and their parent or caregiver with the same openness and the same willingness to be available for whatever emerges during your clinical sessions. And what's amazing about doing that, so basically being a flawed and emotion-riddled human with another human, is that that actually has a positive impact on the person sitting in front of you. So what I mean by that is being a calm and open presence in front of someone who is probably experiencing distress is in fact does in fact have a positive impact on how that person feels. And that has been shown time and again with qualitative research in particular, but also some fairly recent randomized controlled trials on when clinicians are empathic, when they validate the emotions that are expressed by their patients, then the patient's pain actually reduces, or they have better outcomes from whatever treatment they're receiving. So this isn't like hocus pocus, oh, we're hoping that we're, being good people and we're listening just because we're told we should listen. It's actually clinically meaningful to listen and to express empathy and to be responsive when someone expresses something distressing in a clinical moment. So acknowledging emotion is something that I want to talk about a little bit, because I know that in the PIC C program, you have a focus on behaviors that might necessarily be not helpful when trying to move forward with a treatment plan. But I just want to put in a little nugget of information regarding the fact that for every behavior, there's always an emotion. Sometimes it's not obvious. Sometimes it's quite unconscious, but you may, as a clinician, become aware of distress, for example, or anxiety or worry about a particular situation. And just the simple fact of acknowledging that seems like it's worrying to you, or, oh, I can feel maybe you're nervous about that, or even asking the question, how are you feeling about that particular thing that the patient brought up? That acknowledgement of the patient's emotional world is extremely important, because again, that's validating emotion. And everything that I'm talking about right now, and this, I wasn't going to put together a slideshow, but if I were going to use one slide that I do have, it would be an image of the biopsychosocial model as a pie chart, with the biological, the psychological, and the social as three pieces of this pie chart. And all of this emotional validation and communication and bringing in the triad in our clinical relationships, these are all opportunities to have a positive impact on the social aspect of the biopsychosocial model. So I'm hopeful that everything that I just explained makes sense from that lens. That when you're psychologically informed, you have an awareness that the patient has emotions. You have an awareness that the patient has social relationships over which you have no control and that could be causing distress. And you have an awareness that you yourself, as a listener, as a calm presence, as someone open to and acknowledging of the person sitting in front of you and their emotional world, you're actually having a positive impact on that social part of the biopsychosocial model. So I would love to open up for questions. I don't know if we have time for that. I know we got started a little bit late. Maybe Jane, you could advise, or Dermot, you could advise. But if anyone has a question either related to my qualitative research or anything that I talked about, I'm happy to discuss.
I'm told we do have time for questions. So,
We do.
Yeah,
Excellent.
Does the chat function work? Chat function works. So if you if people do have questions,
yeah, feel free. I mean, I know that people probably weren't expecting to ask questions, and I talked about quite a few things in a very short amount of time. So,
I mean, I guess one of the questions that I had is this sort of concept of us. I think what one of the things physios worry about is being a psychologist, and you know we often have this sort of worry about, are we straying into someone else's territory, crossing boundaries, and I think that some of the conversations you and I've had about that are really helpful in terms of our positioning, and that's not really a question, it's more a statement, but that the idea that we're sort of influenced in the social side of the relationship.
mm-hmm. Yes, and I will just say, as far as like not wanting to overstep on scope of practice, what's wonderful and beautiful about simply acknowledging and validating emotion and being a responsive human being and just saying, that sounds really hard, I'm sorry you're going through that. It's just as if you're talking to a friend. You're not trying to solve your friend's problems. You don't have to solve, you probably can't solve any patient's problems, and you're not being asked to. You're just being asked to listen and respond instead of glossing over and pretending that emotion wasn't there. So I completely understand the challenge. You hear, oh, psychologically informed. Oh no, I'm going to have to understand psychology and do. You actually don't. You really need to simply be open and responsive and not feel like you need to fix any emotion that might come into the room. And that in itself, like I said before, can be very healing. Just like when you call a friend when you're distressed and the friend doesn't solve your problem, but they listen. And it's that being heard, the fact of attention that's being cared, that you're being cared for, is extremely healing. And there's a lot of research on this that actually shows, like I said, that just being heard and being validated and having someone respond to you empathically has a very positive impact. So yes, I want to reassure all of the physios in the room, you do not need to be a psychologist, but just having the awareness that emotions are there and that there's probably social difficulties somewhere in the person's life. They're not just a body. And you can definitely help them with the body if they're in a low enough level of pain to move. But I do actually, now that I say that, I want to bring up one of the brilliant interviews that I did for one of my research studies was with clinicians who I said most of them were physios. And one of them, I want to say she had at least 15 years of experience as a physio, probably more. And she was very comfortable just letting the session emerge. And she had a young patient who, for 3 sessions, they did no exercise because the client could not exercise. They just talked. And that worked. So by the fourth session, she was able to engage in physiotherapy. She was already engaged in physiotherapy, but she was just being heard for those first 3 sessions. So I just wanted to throw in that story just to reassure you, you don't have to be a psychologist. You just have to listen, be a person, confirm what you're hearing and say, yeah, you know what, if that was happening to me, I would be really distressed too.
Right. Thank you. So there was just a comment in the chat, but if never, there's some papers appearing in the chat as well.
Oh, good. Yes, good idea. I'll put my website in there too. I've got some blog posts about my research and some other commentaries about other papers as well that you might find helpful.
Super. So if there are no more questions, we're going to move on to Lydia. Thanks, Sarah. So Lydia is our patient partner. So in the sort of the spirit of PIC C, we wanted, when we were starting to get feedback from clinicians, to get patient perspectives on our proposals for developing the PIC C resources. And the lovely Lydia was then part, or had just left your room, I think, hadn't you? And has been our patient partner ever since. So she's going to tell us a little bit about her story.
Perfect. The slides are already up. Fantastic. As Jane nicely said, my name's Lydia. I'm 26 and I have undifferentiated inflammatory arthritis. I was initially informed of the PIC C project through your room. I'm now the young people's involvement and research volunteer with your room. But through this group, I became involved in the PIC C project and eventually developed into a patient partner role. I was able to work with Jane and Claire and others to provide my lived experience as a young person with a chronic pain condition. I was really given the opportunity to weigh in on every stage of the project. I was able to look over every script, make comments on every edit, really was truly involved in the project to make sure that it properly and completely portrayed the experiences of myself and my peers. And I also appeared in some of the videos alongside Jane and the others. So I've remained involved in the PIC C project since the creation of the videos. I was invited to present my experience at the International Symposium of Pediatric Pain last year. I'm here with all of you today, and I'll be involved in a couple of sessions of the PIC C course in the fall. So if you head to the next slide. Potentially, yes. So obviously, a very important part, the key part of the project, is getting involvement from young people with lived experiences. We attended a Your Room online session. For those of you who aren't aware, Your Room is a research focus group made up of young people with rheumatological conditions. So in this online session, we got them to brainstorm some of their ideas about what is important to them when they interact with a healthcare professional. So we got them to write down some of the frustrations they've had, some of the positives, think of any possible solutions to their problems, any improvements they could make to the healthcare system. Basically, what are your problems? What do you want your doctor to do about it? And how do we make things better? So you can see here, this was the virtual whiteboard we had during the session with everyone putting different sticky notes of their thoughts. With this data, we were able to establish the key themes, ideas, like issues and solutions that we wanted to address in the videos. After we did all this data, there were then 3 qualitative interviews with young people, myself being one of them, which was done by the Health Innovation Network team to gather case studies to form the basis of the script. It was very important for us that everything in the videos and in the course are based on real life experiences of the young people and really focusing on what we go through on a daily basis. It can say it was very realistic. It was a bit surreal for me watching the videos be filmed and seeing a conversation that I had had with my doctor be portrayed out in the video almost word for word. So definitely very realistic in that regard. But that was the key point. We wanted to make sure that the young people's values were reflected in each videos and that the scripts were built around real conversations and real appointments that we've all had. This was really the only logical way to ensure that the videos were authentic and representative of everyone's experiences, which made these videos as accurate of depictions as possible of what healthcare professionals can expect to encounter in their daily practice. So if we move on to the final slide, you can see the main takeaways we had from the project. Now, as Claire mentioned, there were 3 videos that we did for this module, focusing on a few key themes, but obviously conflicting values being a key one. I think when we went into the room meeting initially, we expected that there would be a lot of conflicting values between young people and their parents, but we found that that wasn't actually the case, and that the largest issue of conflicting values the young people were concerned about were between them and the healthcare professional. So there certainly are cases where values of a young person doesn't align with their family or their parent. Their main concern was healthcare professionals either not listening or not understanding them, leading to clashes between patient and healthcare provider. These conflicting values led to a breakdown of trust and communication between patients and the healthcare professionals, leading to poorer cooperation, worse treatments. If you're not feeling trusted or open or safe with the doctor that you're dealing with, let's be honest, you're not going to do your physio exercises or anything like that, which is why it was very important for us to address this dynamic in the videos and try to work out possible solutions to improve when you have those conflicting values. As you all know, communication is a key part of any treatment plan, especially transparent, honest, and realistic communication from all sides. I know that the best appointments I've had are when my healthcare professional and I are completely honest with each other. I need to know if a treatment is going to work, and if so, to what extent? How is it going to work? What are the side effects? What are the benefits? What can I expect? And on the other side, my healthcare team, they need to know that I'm being honest about what I'm actually doing, if I'm actually doing the exercises or not, and if I'm taking my medication. So in order for treatment to be successful, there has to be trust between all parties. And this trust comes out by creating a safe space and a routine for transparent, honest discussions that are essential in figuring out what treatment is realistic and achievable for both parties. Finally, the young people and I highlighted the importance of having an appropriate care per person. Now, adolescence is a process, and the young people that you see and treat, they're going to be different people each time you see them. It's just a case of life, just growing up. So it's important to keep in mind that these people are constantly changing between appointments, and to try to provide appropriate care that is relevant for each person. Young people in general struggle to balance full-time school, hobbies, friends, sports, and social commitments, regardless of if they have an injury or a disability. When you add physical pain and chronic pain on top of all that, life's pretty hard. I've been lucky to have a healthcare team who try to work my treatments around any hobbies or activities that I'm already doing. And that has really given me the greatest chance of actually doing them and working them into my daily life. It's worked for me and for my physios, and has been an example of that best practice care that I'm lucky to have received. And that was in one of the examples we wanted to use in these videos. Now, as some others have said, especially Christine, it's this type of collaborative and positive treatment that I hope continues and expands throughout the continued development of the PIC C project, especially through the constant involvement of patient partners and listening to those with lived experiences, which make the program as authentic as possible. And I think by involving patient partners to the level that PIC C has made it clear that the work that's being shown around the world is truly being impactful and is relevant for everyone experiencing that. So thank you very much. I know we're a bit behind schedule, so I don't want to take up too much time.
Had to be unmuted there. Thank you to my glamorous assistant. Thank you to all of our speakers as well. I think we'll pause and just check if there are any questions, maybe for Lydia, if that would be okay, or on any of the topics that we've heard about so far. So I'll just pause in case anyone is typing into the chat, or even unmuting themselves to ask anything. Okay, well, maybe as the ideas are kind of percolating for people, we will think a little bit now about some future directions for PIC C and closing remarks. So I'm looking at my esteemed colleagues around the room and wanting to pull together some of the really exciting conversations we've had this morning about where we want to go next with PIC C. So this event is really celebrating 6 years of working on this project. And what we'd like to do in the future is move PIC C onto a firmer footing whereby we can really open up the opportunities for people to benefit from PIC C by advertising the course more broadly, by really progressing the conversations that we're having with people across the UK, but also internationally, and we've heard of some of those innovations today. And we would very much welcome the people on the call today. If you have any ideas, if you'd like to join in with the PIC C training, if you'd like to share any ideas about how you feel we could progress PIC C in the future, please feel free to contact us via the PPA and share any ideas that you have. I'm going to pause there and just check with Dermot.
Yeah.
I think Dermot's going to bring up another slide for us. So bear with us just for a moment. As you can tell, it's Friday afternoon. The tech is not with us.
Well, yep.
Fantastic. So hopefully. Oh.
What's it showing? Sorry. Apologies, everybody. What can you see?
That's it.
Fantastic. Panic. Okay, so as I sort of started to talk about, we want to build on the diversification of PIC C and look at other clinical areas. Just as we've taken PIC C into the paediatric world, we're very aware that PIC C can perhaps go across other populations, maybe other kinds of persistent symptoms. So again, we'd be very keen for you guys to reach out, collaborate, join with us, think about how we can use these ideas to really support people to live well with a range of very challenging conditions. As part of that, we are going to explore routes to accredit PIC C, possibly through the personal care institutes, And that will again help us to promote PIC C and to be able to make this programme visible to people who are looking for ways to improve their practice through incorporating psychologically informed collaborative conversations. We've been very, very fortunate today to hear from two amazing patient partners, people with lived experience, and we're very aware we want to continue that journey to open out the options for more involvement. And this morning we've been talking about how we might be able to increase participation of patient partners in the PIC C programme itself, looking at evaluation and beyond that as well. We would really like to find ways of trying to look at evaluating what impact PIC C has on the kinds of conversations that clinicians are having with the people that they work with. That is a very kind of knotty problem. So if anyone has any amazing ideas about how we might do that, again, we would be very pleased to hear from people. And I think the QR code that is being shown is how to link with the PPA. So for any questions, any comments, any way in which you think PIC C could be helpful to you or your colleagues, we'd be very happy to hear those ideas. I think that's probably all I want to say to this slide. So I'm just going to turn to my colleague and say, is there anything in the chat that we need to respond to? Oh, okay. Well, in that case, I think I will probably bring the meeting to a close and thank you all for staying with us on what's certainly an incredibly hot afternoon here at Input in London, and I'm sure it's the same with you guys. I think I can just see one thing in the chat as well. Thanks. Well, that's a good way to end this afternoon. So thank you, everybody. And we'll look forward to hearing from you with anything you'd like to share about PIC C. And thank you to all of our presenters as well. You've done an amazing job, and enjoy a long weekend, everybody.